Thank you, Jay, for inviting me to this great symposium. And this is a case of a glass blowing intraocular foreign body. This is a 25-year-old person who was a professional glass blower who developed a foreign body sensation in floaters while glass blowing. He was wearing safety glasses, so it wasn't exactly clear the mechanism of the injury. When he came in, the vision was 20/20 in each eye. He had no APD, the pressures were normal. And in the left eye, he had a conjunctival hemorrhage, some mild conjunctival chemosis. The cornea and anterior segment were otherwise unremarkable. This is a photograph of the right eye, which looked great. And in the left eye, you can see an area of hemorrhage subarachnoidally that's sort of linear in its shape. But otherwise, the retina looks pretty good. And when you focus in on this area, you can see what looks very much like a puncture site. And then when we're doing extended ophthalmoscopy, in addition to the hemorrhage, you can actually see a piece of glass that was impaled in his eye. So it went in approximately through the pars plana and then impaled itself into the retina, probably through the sclera, where a piece of it broke off and was just sort of stuck inside the eye. We then got a CT scan, and you can see one piece, but there's a sense that there's multiple fragments of glass in his eye, not just the one that was visible on extended ophthalmoscopy. And so we took him to the operating room. Here's his main entry site. It's about 5 millimeters posterior to the limbus. And when we went in surgically, he was young, so we had to induce a PVD. You'll see that there's this piece of glass here, but then there's multiple smaller pieces of glass. What we think happened was he had a fairly long, maybe 3-4 centimeter thin piece of glass that went into the eye. And once it impaled in the back of the eye, it started to break off into multiple smaller fragments, which were then lying on top of the retina. What? We lifted the hyaloid up, which I think is an important thing to remember in these cases. And here's, you can see his original entry site. We then enlarged the primary wound. And then we started removing the pieces of glass. Removing these pieces of glass was quite tough, partly because the forceps weren't really wide and they were long and tubular. So it was difficult to get a good purchase on them, but eventually we were able to remove them. One thing that we found to be very helpful is to make your sclerotomy somewhat larger than you would think necessary. We lasered the brakes, and then of course we put in oil tamponade in this individual for a total oil fill. And then the next day, a week later, he looked pretty good. There was a small little bit of retained perfluorocarbon liquid pre-retinally, but the macula looked good. All the laser areas were well treated, but 2 months later, he developed bad PVR, and then with several additional surgeries, he ended up remaining attached without oil, but the vision had deteriorated to count fingers.
Excellent. Very nice. Dr. Giridhar, do you have any comments on this case?
Yeah, very nice presentation, actually. When I saw this, the title as Glass, I was reminded of a similar case which we operated here about 20 years ago with multiple glass pieces in the eye. And what I wanted to ask Sunir is, what's the instrument you use to remove the glass piece? Because standard IOFB forceps, usually it's very difficult to get a grip on the foreign body. It just slips. And second thing is the edges are very sharp. So getting it through a sclerotomy, even after enlarging, is not at all easy to get the glass foreign body out. Because in that particular case, of course, the size of the foreign body was multiple foreign bodies, some of them very large. Finally, we removed the lens and removed the glass through the anterior segment. That is, we brought it to the anterior chamber, and then we removed it through the anterior segment because we found that removing it through the pars plana was very difficult. So I just wanted to ask you, what's the instrument you use? What were the intraoperative difficulties? Because since you PVR, that means you had a lot of surgical difficulties in removing the foreign body, most probably. That's the reason why probably there was so much of PVR and the final visual outcome was quite poor.
He had multiple puncture sites when we were intraoperative. And whenever you have hemorrhage and then liberated RPE, obviously the incidence of PVR is going to go up a fair bit. But removing the glass is very tough, simply because the grass in this case was round, and you're trying to grab something smooth with forceps, so it kept on wanting to pop out. Luckily, we just used good old-fashioned 20-gauge serrated forceps, and the pieces were small enough that we were able to grab them on the long end and withdraw them. But some things that we had talked about using were to put in a chandelier for a bimanual technique to sort of change the orientation of the glass. Ideally, you would have something that would be rubberized. If you had rubberized forceps, that would be helpful. I've seen other people that have used something like a finesse loop, which is a retractable loop, which people use sort of like they would a Tano scraper. And then you could use that to lasso some of the pieces, tighten the loop up, and withdraw it from the eye that way. That's another option that was available. But glass in these cases can be really tough to remove.
Right. I think the good part is that the retina was attached in the beginning, so you did not face challenge, because when I saw your video, it just reminded me of one of my patient who came with large glass foreign body with the sharp edges with detachment. So that gets really difficult, because the glass edges are really sharp, and deal with the detachment and taking it out was a nightmare. Excellent. Gopal, do you have any comments?
Glass is actually very, very complex, because the shape of the glass itself is sometimes very difficult. So either it could be a globular, larger glass particle with multiple sharp edges. Even if, like Giridhar said, if you are taking it through the cornea, you may have to actually enlarge the opening significantly, because otherwise it will completely damage the corneal, the tunnel through which we are operating, removing it. And as Sunir was telling, it's extremely difficult to hold that with forceps. So some people have used diamond dusted forceps. Some people have used snares. I think there is a renal calculus remover, something which is there, which is another instrument in which there is either a lasso or something like a basket-like thing into which you could hold the glass piece and then take it out. These are some of the atraumatic ways of removing the glass. Another important problem is whenever we are trying to remove the glass, it may break in our hands. So during the removal itself, it could break multiple times, and maybe it will lodge in the pars plana, which is even more difficult to remove at that point of time. So getting that out, and once you have this multiple pieces inside and when you are taking out, I think the vitrectomy needs to be really very thorough.
Right. Anybody else has any quick comments? We still have a few minutes.
Can I show one of my videos where we dealt the glass foreign body?
How many minutes do you have?
Just a minute.
Sure, definitely. Go ahead, Vinod. It's always fun
you'll have to
see.
share unshare, Sunir.
Lalit has asked a good question. I mean,
I was till the time he puts up Vinod, because in India the patient reaction, you see 6 to finger counting, he will blow you out.
Okay. Yeah, Sunir, he means the patient's reaction towards the count finger, not PVR reaction, which is sometimes more scary.
Yeah, I mean, these are tough conversations. I mean, when you see it, he was a glass blower. He was looking up at one of his objects, and then a piece broke off. And it's always tough when a patient comes in with, good vision, just a little bit of haziness and some irritation. Sometimes it's important for us to explain to them how concerned we are for their future, not with what's happening right now, and how the body's own healing mechanism can sometimes work against them. So that preoperative conversation is hard, but I think it's critically important to help frame what we anticipate happening over the next few months or a year.
Right. Vinod, go ahead. Let's see what you got.
So this was a young guy who had come to us with the repaired corneal puff elsewhere with the cataract. He had injury with a basically ruptured bulb. So a glass piece went inside. So once we managed the lens, so this is what we found. There's a large glass piece, and it has already punctured the papillomacular bundle. So I tried to lift it with edges, but could not hold it. But finally, I used the light pipe to slide beneath it, and then 20 gauge serrated forceps to hold it. So once it was there in the grip, it was easy to remove through a corneal wound. But just to, again, the point has been well highlighted that the edges are sharp and it is really difficult to hold it. So
yeah. I think that putting a chandelier and handling with bimanually was a very important suggestion, because that is something which avoids the edges and avoid damaging the retina around. So that helps. All
EFCL
right.
in these cases, do you think that they
One
will
point to
actually...
add here, sorry, during diagnosis ultrasonography, because very typical features you get, like because of multiple reflecting surfaces, lot of your, sometime you can erroneously diagnose as a multiple foreign bodies rather than one single foreign body. That also you need to keep in mind.
Yeah, that is true.
Yeah, just
EFCL does not erase the glass particle many a time, most of the times. I think.
Yeah. Raja, you wanted?
just a brief point. One of my patients is a medical student driving, and he crashed his BMW. The glass windshield broke into multiple pieces, and some of us can be lucky the way Vinod showed. At least he could grasp it. Some of them are so irregular and huge, you just cannot do anything. I had to use a vectis and make a large corneal incision and float it up, and ultimately after that use a vectis to pull it out. So all these cases are extremely challenging. You really have to be innovative when you take care of them.
Absolutely.